Ladies and gentlemen, thank you again for inviting me. This presentation will be about the surgical treatment of recurrent stress incontinence in women. The background for this: in the UK, we had an epidemiological register-linked study of almost 37,000 women, and we established the lifetime risk for the first time in the UK for women to have primary stress incontinence. We were surprised that the lifetime risk by age of 80 is 3.6%. Out of those, almost 9% will have a repeat continence surgery for what they described as recurrent stress incontinence. The average time for this is about 3 years between the first and the second procedure. Another study from Denmark have shown that the cumulative incidence of recurrent stress incontinence surgery is 10%. So almost agreeing with our percentage of 9%. However, they had quite large variations depending on the type of the index procedure. So it depends on the type of primary surgery they did. They found different percentage of recurrent procedures or second procedure for incontinence. So it's about 6% if you've done retropubic TVT or Birch or autologous SLING. I'll repeat that again. So the chances of a woman having a repeat surgery, a second procedure after retropubic TVT or Birch or autologous SLING is around 6%. About 9% if the primary procedure was transobturator tape. And about 44% if the primary procedure was urethral bulking. This is a little bit unfair for urethral bulking because we know urethral bulking anyway works only for 2 to 3 years by maximum. In the States, they found that the incidence is about 14.5% within 9 years of follow-up. When the same group repeated their study but excluded women with primary procedure for urethral bulking, they found the risk is only 5.2%. So you can see, in the States, 5.2%, in the UK, about 8.8%, and in Denmark, it's about 10%. What do we usually do for women with recurrent stress incontinence? Well, the rule of the thumb is that conservative treatment is the first choice. But do we have an evidence for this? The answer is no. Pelvic floor muscle training, biofeedback, drug therapy, the commercial continence devices, that things that you could put like a plug to block the urethra, or you put it in the vagina like the large tampon that we were talking about in order to obstruct the bladder neck, they all can be used. However, they have never been assessed in the context of an RCT. I've told you in the UK we have something called the NICE guideline. It recommends conservative therapy as a first-line treatment. The Canadian guidelines recommend pelvic floor muscle training as the first-line treatment. And I would find very little opposition to say that it is accepted worldwide as a good clinical practice. Because if you're only going to get 1 in 2 women to improve on it and the other 1% or the other 50% will need surgery, then you've gone away with 50% that did not require a further operation. We've done previously a survey in the UK to see what would people do, and we found that 80% of the UK responding gynecologists that survey would recommend pelvic floor muscle training as a first-line treatment. As you can see, I'm going to the next slide without telling you does it work or it doesn't. And in fact, we don't know, because we've never assessed pelvic floor muscle training or pelvic floor exercise for women with recurrent stress incontinence. The surgical management, as you know, would be challenging, depends on a number of factors. What was the type of procedure, the index procedure? How long did it take to fail? Are there other factors like the patient have increased her weight? Have she started a new job? She became a cook and she's lifting a lot of objects. What's her expectations? I would like to be totally dry, a little bit of an over-expectation. Also, what are the surgical experience available in the institute where you work, and do you have the appropriate investigation? Our guideline says that women with recurrent stress incontinence should be referred for tertiary centers. so that they can have the full access for all the investigations and the full access for all surgical treatment options after multidisciplinary team approach. That means that I sit down with my urologist and physiotherapist and continence nurse and discuss each case, and then we decide these are the procedures that we would be offered for this patient, or we do it the other way. I discuss with the patient, we take a decision, this is her preferred procedure, and I take it to the MDT, and we either agree or disagree on that. There isn't usually a lot of fighting in these meetings. It's usually an intelligent discussion that ends up for the benefit of the patients. And I wouldn't be embarrassed to say that some of the time my physiotherapist got me to go back to the patient with options that were very beneficial for the patient. The NICE guidelines say that these patients should be offered the 4 procedures. If they choose surgical treatment, they should be offered all 4 procedures: TVT, colpo, autologous, and urethral bulking. So, as I mentioned, we've done the clinical survey, and we found that almost 80% would recommend pelvic floor muscle training. 80% would then proceed for a midurethral sling retropubic TVT if the patient requires surgery. And 50% would only consider bulking agents, and 1 in 4 would consider open colpo suspension, and 1 in 5 would consider autologous sling. And I noted here that this is in 2012. I mentioned things have changed, and I showed you before the figure for how the operations for incontinence have dropped in England and in Scotland. What this is showing you is the data from British Society of Urogynecology surgical database, showing the operations for recurrent stress incontinence between 2007 and 2016. The lovely big blue column is the midurethral sling. So you see it was almost 80% in 2007 and coming down to about 50% in 2016. The red one is the bladder neck injection, and you can see a sharp rise that compensate for the TVT. That's not because people do not want to do autologous or colpo, it's because of the availability of the surgical expertise, as we said before. The fascial slings are also on the rise, and I want you to see that in 2007 there were none. And in 2016 there is about 21%. And this is where I'm showing you the difference in the operations that we have in the UK. So what is the current best available evidence? Well, there was a systematic review of observational studies that were done to find out midurethral slings for treatment of recurrent stress incontinence. They wanted to evaluate this. This is done by my by my colleague groups in Birmingham, and they have shown that up to 30 months follow-up, the success rate was about 78%. It was dropping to about 73% if it was a repeat tape. So the difference is, if you had a colpo and I'm doing a tape for you, then your success rate is around 78%. If it was a tape and then I'm doing another tape, then it's around 73%. This is not too far from the results that have been published in the continent. In 2015, there was another systematic review looking at the same population, or the same cohort of women, and they showed us that the success rate for TVT is significantly higher than if you do transobturator tape as a second continence procedure. Now, as you can see, the numbers are talking for themselves, 72.8 versus 55.4%. Both reviews were limited by the fact they were observational studies. Now, observational studies are liable to bias. So if you do meta-analysis of biased study, you get a biased meta-analysis. And therefore, the results of this evidence is okay, however, you cannot base your decisions on. So we've done another meta-analysis, that's my group, and has done this in order to look at the randomized control trials, which is the cornerstone of evidence-based medicine. We looked at the patient-reported outcomes and the objective cure rates, and also we looked at a number of secondary outcomes. We included any study that had follow-up more than 6 months and did not exclude women with recurrent stress incontinence, and we contacted the authors to find out what are the results for this subgroup of women if they haven't published those. We looked by a Cochrane risk of bias. We assessed using the Cochrane risk of bias and Jaddad quality assessment tool, and we've done sensitivity analysis. Busy slide, I'm sorry for it, so I will just say that we had subgroup of 60 studies that included women with recurrent stress incontinence, that's 60 RCTs. We were only able to get out of them 22 studies, and the rest were either uncomparable, so basically they included the recurrent stress incontinence, however they only had recurrent stress incontinence in one arm, or the authors did not reply us, or the procedures were different from the comparisons we identified. So I'll just jump into the meta-analysis. And for those that do not, like me, do not understand meta-analysis a lot, you have one side says favor transobturator. So this is a comparison of patient-reported outcomes of transobturator tape versus TVT. If it goes that side, then it favors transobturator tape. If it goes that side, it favors retropubic. And if it touches the midline, then there is no difference. And you can see patient-reported outcomes is bang on the middle. Objective outcomes, again, is bang on the middle. Sorry, just going back into this. Now I compare this to what I've told you before about the observational studies, where it had showed clear advantage of retropubic TVT. This is why I'm saying to you, when you look at the evidence, you have to be critical about it. The first one, observational studies, biased. The second one, they are RCTs, however, they are a small number, and I'm going to let you know why this evidence is poor. When you looked at TVT versus Birch, again, patient-reported and objective cure are bang on the middle. The retropubic versus Birch have a shorter operating time for retropubic TVT. What about retropubic versus autologous SLING? You could see for patient-reported, for objective cure, for patient satisfaction, every one of them is crossing the midline, which means no difference between both. The same for Birch versus autologous. However, you see that there is a trend towards better success rate with autologous SLING. Now, this is one RCT. However, it's a good quality RCT. This is the Brubaker group. Inside out versus outside in. This is my study, and it has favored the inside out for inside out TVTO for recurrent stress incontinence. However, it's still touching the midline, so it's insignificant. It's 0.06. So, we looked at the Cochrane risk of bias, and we found that we had 6 high-quality studies and 6 low-quality studies. How do we interpret this? The strengths of this review is that it only included RCTs. It was a thorough literature search, and we had long-term follow-up data. We called that more than 1 year. The limitations, there were limited number of studies, there were limited number of patients. The RCTs had groups of women with recurrent stress incontinence. Now this is important. This was not a cohort of women of recurrent stress incontinence and then we randomly assigned them. They were subgroups of women with recurrent stress incontinence, and we also had a low author response rate. What did we find from the trends? If you do a retropubic TVT, you have higher chance of having a bladder injury. So what? We know that before. The comparison did not favor any specific procedure. However, there were trends toward better outcome with autologous if you compared it with colpo, and the inside-out transobturator tape if you compared it with outside-in. And the retropubic had shorter operating time compared to laparoscopic colpo. The evidence from this systematic review shows us that the current evidence to base our decisions on is extremely poor. We are really in desperate need for a randomized control trial about women with recurrent surgical treatment for women with recurrent stress incontinence, and I'm pleased to say that this has been commissioned in the UK, and hopefully it will be starting in about 8 or 9 months' time, where we're going to be comparing these 4 procedures only in a cohort of women with recurrent stress incontinence. It's a £2.6 million study, so hopefully it will work well. So what do I do until that study comes? Well, I look at the women with recurrent stress incontinence when they come to me as 2 different categories. The quick example, I had my operation a few years ago, but it never worked. So I call that persistent stress incontinence. And my differential diagnosis, either this was an incorrect diagnosis, there was an improper selection of the procedure. For example, you choose to do colpo while there was intrinsic sphincter deficiency, or you choose to do a TVT with a tethered vagina, as we heard before. The surgical expertise Has it been done by a surgeon with a low case volume? And also I put in mind that after the recent mesh saga, we had a lot of people that are, or we have a number of surgeons that were restarting the learning curves and retraining for colpon autologous slings. So inevitably, there will be lower success rate with them. However, the other scenario is, my colp suspension worked very well for the last 12 years, 20 years, and now I'm back with other stress incontinence. Have the patient developed further risk factors, so has now put on a lot of weight, or have this patient changed job, as I mentioned, and she become athletic, and now she's getting a lot of exercise? Or is it just a true progression of the disease, and she now has further hypermobility, or her hypermobility has now been aggravated by an ISD? We try to reach a good diagnosis by proper assessment, and the most important part here, I would say, is the history taking. I use structured pelvic floor questionnaires, like the ICIQ group, and I add for it the urgency perception scale. The aim is to differentiate and reach a correct diagnosis. Is it a USI, is it a mixed incontinence, or is it actually an OB that we have missed? And also I would like to know what's the impact on their quality of life. Is the treatment I'm going to do going to be worse than the disease? She had 3 operations before, and I think I'm the best surgeon in the world, and I'm going to do her 4th. It's going to be a larger operation. She's going to be staying in the hospital for about 3 to 4 days, and she'll still be incontinent after it. However, she's going to have even worse by voiding difficulty. Remember, the first rule of medicine, do not do harm. So I would counsel the patient, if her score is about 3 to 4 out of 10, I would say, do you really need surgery or not? I'm talking about quality of life here and botherness scale. The second one that I depend a lot about is the bladder diary. I want to see, is the patient passing small volumes of urine very frequently? Is that suggestive of overactive bladder? Or is she passing good amounts of urine, and when she's leaking, she tells me that she's doing that during time of exercise or increased intra-abdominal pressure? I assess for urethral hypermobility, and I don't do special tests. I don't do the Q-tip test. I look at it when the patient is coughing. Is there hypermobility of the urethra, or is it a fixed urethra? And then I would go for my investigations, which will almost invariably have a subtracted cystometry and the urethral pressure profile. And I raise my hand and I say that urethral pressure profile in my hand works. However, I know that there is no evidence behind it, and that in fact, what is the cutoff value? Is it 30 centimeter water, or is it 20 centimeter water? Would you put that together with a leak point pressure or not? I know that's quite a sophisticated debate, which I'm not going to go into, but urethral pressure profile and leak point pressures are used. I know that ultrasound scan is used as well. However, I do not have an experience with it, and I'm talking about my personal experience. So which operation? Then I'll follow the Canadian guidelines. So I said that the woman has got true recurrent stress incontinence or stress predominant urgency mixed incontinence. This woman has got high impact on her quality of life, and she has failed conservative treatment, and she wishes to go for further surgery, and she understands the risks. Then I'll probably will discuss with her either autologous sling or a low tension TVT. At the moment, we don't do TVTs, so I'll discuss with her autologous slings and perhaps urethral bulking if she fits the criteria. I'll finish with the EAU guideline about women with recurrent stress incontinence. As a rule of thumb, the retropubic midurethral slings is an evidence-based management for women with recurrent stress incontinence. If you compare the transobturator and the retropubic, there isn't really too much difference between them. However, as I mentioned to you, there is one systematic review of observational studies which have gone in favor of the retropubic TVT. The long-term analysis of the midurethral cohorts have shown sustained response beyond 10 years. However, the transobturator is associated with risk of groin pain. My own study have shown that the groin pain at 9 years for a transobturator tape is 4%. 2% of them are taking painkiller, and 1.5%, which was only about 2 patients, these patients required removal of the tape. These are my own results in 341 women with transobturator tapes. Incontinence surgery may be safely performed in obese women. However, outcomes can be inferior. The sexual function may improve and may not. Thank you very much for your attention.